Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 36th episode of Optometry series. I'm very happy to welcome my team members, Ms. Anshika ma'am. Hi ma'am. And Ms. Meenakshi. Thank you both of you for joining with us today. And we have a very special guest today. Ms. Deepa ma'am has joined us. Thank you so much, Deepa ma'am. Yes, Anshi ma'am. Thank you so much. Anshi ma'am, so what is today's topic?
So today's topic is about workup for a Lasik or a refractive surgery. And from the time I was studying, Deepa ma'am has been there teaching us, guiding us about how to do the workup. So I think nobody better than Deepa ma'am would have moderated this session. So thank you, Deepa ma'am, for joining us. Gokul, I would like you to please introduce Deepa ma'am, and then we can move on to the exciting topic today.
Hello everyone, welcome to the episode 36 of our optometry series. I am Gokul, currently in my second years of Bachelor's of Optometry at Dr. Agarwal's Institute of Optometry. We have a very special guest as our moderator who has made significant contribution to the field of optometry and has extensive experience in corneal diagnostics. I am very happy to welcome our moderator, Ms. Deepa ma'am. Ma'am has completed her BSc Optometry from Mahatma Gandhi University in Kerala. She brings with her an impressive 23 years of clinical experience, showcasing her dedication and expertise in the field. Currently, ma'am is working as a senior optometrist in the Department of Refractive Surgery and Corneal Diagnostic at Shankar Nethralaya in Chennai. Thank you so much, ma'am, for joining with us today, ma'am.
Thank you.
The speaker for today is Ms. Smruthi Sivakumar, pursuing her third year bachelor's in optometry at Dr. Agarwal's Institute of Optometry. Ms. Smruthi, please start your presentation.
Good afternoon, everyone. Introduction. The long-term efficacy and safety of photorefractive keratectomy (PRK) and laser-assisted in situ keratomyolysis (LASIK) for high myopes irrefutables. A detailed preoperative screening and optimization of the ocular surface prior to the refractive surgery are the key to minimizing the incidence and severity of post-operative complications. Modern corneal refractive surgery offers a choice of procedures such as LASIK, SMILE, and PRK, all of which are associated with a high index of efficacy and safety. The goal of refractive surgery is to reduce dependence on contact lenses or glasses for use in routine daily activities. A wide variety of surgical techniques and technologies are available, and all require appropriate preoperative evaluations to determine the best technique and ensure the optimal outcome for each patient individually. LASIK. LASIK is a type of refractive surgery. LASIK surgery is the best known and most commonly performed LASIK refractive surgery to correct vision problems. LASIK can be alternative to glasses or contact lenses. This kind of surgery uses a laser to treat vision problems caused by refractive errors. You have a refractive error when your eye does not refract the bend light properly. When it is done, requirements are 18 years or older, ideally over 21 years old, when vision is more likely to have stopped changing, and no significant change in the prescription for last 1 year. Prevalence. About 20 to 25 million pairs of eyes have undergone the major of LASIK treatment. The LASIK surgery success rate 2023 is given below. So this is a diagram how the LASIK is done in our eyes. Procedure. Step 1. The cornea before it is cut. Step 2. The surgeon creates a corneal flap, which is a thin slice of the cornea. It is cut and flipped open like the cover of a book. There are two methods of cutting the flap: using a microkeratome, which involves a blade, or femtosecond lasers, which are bladeless. Step 3. Once the flap has been cut and opened, an excimer laser is used to remove tissue from the center of the cornea to reshape it. correcting the patient's refractive error. Step 4. After correcting the cornea, the flap is replaced, like closing the cover of a book, and allowed to heal naturally without stitches. Clinical significance. While LASIK may be used in refractive error, it was shown that this procedure is reliable in patients with myopia of -6 diopter or less and astigmatism of less than 2 diopters. A recent meta-analysis study showed similar improvement of visual acuity and patient safety with LASIK compared to other refractive surgical procedures. This procedure has the added advantages of rapid recovery and decreased post-operative pain. Several studies report a 90% to 95% rate of satisfaction among patients who obtain LASIK surgery. About 9 of 10 people, 90% who have LASIK, end up with vision between 2020 and 2040 without glasses or contact lenses. More than 8 out of 10 people who have undergone LASIK refractive surgery no longer need to use the glasses or contact lenses for most of their activities. Lasik workup is done in these different kinds of techniques like slit lamp, pentacam, vision check, fundus examination. Psychologically, patients should be highly motivated, procedure to be considered based on the needs of the patient. It should meet the expectations of the patient. Details ocular history to be taken like refractive status, use of contact lens before, dry eye syndrome, history of surgery or trauma if any, history of any infections, general health history include to rule out metabolic disorders, autoimmune disorders, etc. History of medications if any. Refractive history, rule out onset of refractive error, age, stability, presbyopic or anisometropic. Contact lens history, type of contact lens used, wearing schedule to be documented, type of cleaning solution, cleaning practices should be asked, using contact lens should be stopped 2 to 4 hours, 2 to 4 weeks prior to examination because it alters the topographic features of corneals. Regular astigmatism changes the amount, type, and axis of astigmatism can alter corneal thickness. Examinations like visual acuity like BCVA, UCVA, refraction, slit lamp and pupil assessments, tear film assessments, IOP measurements, fundus examination, curvature analysis, and corneal thicknesses. Vision and refraction. To know the visual and refractive status of patient, to look for any infections, trauma, or past surgeries, to determine the outcome based on systemic and ocular health. Slit lamp examination include to rule out any ocular pathologies, pupils to check for optic nerve functions. Fundus examinations include to determine the post-surgical outcome, to rule out pathologies, IOP to be monitored. Tear film assessments like eyelid position, blink dynamics, tear meniscus height, TBUT, streamers, meibomian orifices, tear film debris pattern, cornea and conjunctival staining. Imaging techniques of cornea. It is the most important screening test for refractive surgery to detect abnormalities, diagnose early cases of ectatic corneal diseases, and classify these diseases, diagnose post-keratorefractive ectasia, and to plan for the best choice in refractive surgery. It gives both ocular surface and readings and thickness map. This is the image given here. Wavefront science. One of the major applications of wave theory of light is in wavefront analysis. Currently, wavefront analysis can be performed clinically by 4 methods: Hartmann-Shack, Cherning, thin beam single ray tracing, optical path difference. Measures lower order aberrations like sphere and cylinder, and higher order aberrations include spherical aberration, coma, and trefoil, used in calculating custom ablations to enhance vision. Types of refractive surgery. Ocular, intraocular includes phakic and pseudophakic. Ocular includes incisional, excimer laser, non-laser lamellar, collagen shrinkage, collagen cross-linking. Thank you, ma'am.
Thank you, Smruthi. Mute. Just a minute, ma'am. Thank you, Smruthi. And ma'am, I would request you to add your points now, ma'am.
Hi, am I audible?
Yeah, ma'am, it's very clear.
Yeah. First of all, I'd like to thank Punitha and the Agarwal Institute of Optometry for giving me this opportunity. And thank you, Mr. Gokul, for introducing me. And Smruthi, it was a nice presentation. It was informative. So from my experience, I would like to add some points because as optometrists, we play a major role in selection of the LASIK patients because it is an irreversible surgery. So we have to make sure the patient doesn't have any abnormalities and should not end up in any problems post refractive surgery. So selection is very important. So I would like to add some more points which we generally use in our OPDs. to get the maximum result. Okay. So I'll classify this Lasik workup into two major components actually. First is the basic pre-Lasik workup and the pre-Lasik evaluation, which in process scan. So the patient generally comes into our OPD, like what she said, highly. So we'll start with the history taking. We have to ask what is the purpose for which you have come. Is that a cosmetic reason or a job reason or some other job where we have to be off the glasses. So what is the purpose is very important. And some people would have come for social reasons like pre-marriage, like that. And we have to ask for whether any complaints is there. If there's present glasses, is the patient happy? You can clear with your existing glasses because that will give a clue of whether the car is stable or not. And whether he is having any other complaints like floaters or flatters or any other system irritation. All the complaints have to be asked. Next comes the contact lens history. If the patient is a contact lens user, if it's a soft contact lens user, he has to discontinue the contact lenses for 2 weeks prior to the evaluation, even the pre-active work. If it is an RGP user, we recommend 4 weeks of discontinuing the contact lens. Otherwise, the impact will be there on all the weeks. So we have to make sure by the patient take the appointment itself. It will be better if the secretary or whoever takes the appointment is aware that they have to inform the patient about the case. Otherwise, it will be a waste. The patient traveling all the way here and going back and coming again. So the contact lens history. And as we said, all the contact lens history have to be asked. And if possible, the contact lens power also has to be asked on the patient. And coming to the ocular history, for how long the patient has been using power glasses, and if he wearing it regularly or he just wore it today for the checkup, we have to have adaptations for the existing power. And the power should be stable for at least the past 6 months. And next we have to ask for the nature of the, if he is involved in any sports activities or like boxing or something where there is a chance of injury to the eye like that. So that has to be asked for. Then coming to the retinal evaluation, like before the evaluation, you have to ask the history. Like some patients would have undergone some retinal treatment. If they had retinal holes, they would have undergone barrel for the holes. So we have to ask how many patients of barrel has been done and then was it done. Mainly because at least 3 weeks should have passed for the retinal barrel. So that history has to be taken. If the patient has any old reports with him, if he has any tentative reports or any reports with him, that has also to be taken care. We have to report the findings whichever are available and any previous injuries, surgery is done, all those things. Okay. And then regarding the dental health, we have to ensure the patient is not pregnant or lactating. If the patient is married, we can ask her regarding pregnancy, lactation, fertility treatment, any hormonal medication the patient is using, because there might be fluctuations, so we want adult lactation in this case. And some autoimmune diseases, collagen vascular diseases are all contraindicated. And general health and this pregnancy lactation. If the patient is lactating, you have to ask the patient to stop the lactation and come back after 3 months of stopping the lactation. So that's our stable. Okay. And next we have to ask for medicinal use, family history. If the patient has any family history of corneal dystrophy, presentation, or keratoconus, aesthesia, family history, that plays a very important role. It is also contraindicated, so we should not forget to ask family history. Then if the patient is using any medication, that also has to be asked for. Some patients will be taking some acne treatment Those are also important. We need to get the clearance letter from the dermatologist involved in hormonal medicine or anything. And medication, like any other medication, all medications have to be recorded. Drug allergies, as I told, have to be recorded. And now we go on to the vision check and refraction aberration. So vision check with the current glasses, the patient is having very less power, the like 1.5 or less, we have to do a uncorrected vision check also. And then we will go on to the refraction. So we have to make sure the power is stable. If the current glasses power and our refraction value is matching, then it is stable. But we have to ask them how old is the current glasses. Some glasses might be very new. So we can't say if we have bought a very new glasses within months or something, we should ask for a previous glass prescription within 6 months with that. If the older the better, if it is matching our current. If it is not available, ask for a contact lens prescription, which can be taken, and you can see the power and you can control the water power. And so the refraction. We can see some patients who are over-corrected, who are wearing over-corrected glasses and coming to the clinic. So they would have got adapted to the over-corrected power. So what we have to do, we have to give the correct refraction. Diophragm test is very important. I think you all are doing diophragm in your clinic. Give a diophragm balance prescription and give adaptation for 3 months at least with the new power. Otherwise, the patient will not be comfortable to directly go for a under-corrected to give adaptation, which is not comfortable. After the patient comes back after 3 months, you have to re-refract, do the re-refraction and make sure the part is stable. And then you can proceed with the further evaluation. Then,
Excuse me,
then
ma'am. I'm sorry to disturb, ma'am.
Yes.
Like the sound is very low, ma'am. Can you please adjust your mic and see once?
Hello, audible?
Yeah.
Hello,
It's audible.
Hello?
At the...
hello.
Yes, ma'am. It is audible now.
Okay, okay. I think I have to. Should I repeat anything?
No, ma'am. It's fine.
Hello,
It's fine. It's fine. Yeah.
Oh, okay. So I was telling about correct power, means the no undercorrection, no overcorrection. Correct power has to be given to the patient. If it is an overcorrected patient, you have to give the correct power, give the adaptation for 3 months, practice 3 months, and then go for the further evaluation of the patient. And next is the refraction part is done. But see, some cases we have seen that they are the optometrists are not very keen on doing JP. Actually, JPC plays a very major role. We should not think that we have done an exact refraction by just taking the cylinder. Very importantly, you have to do JPC and diophragm. That will help a lot in finalizing the exact final power solution. Then coming to the photographic pupil size. Notice the size of the pupil in the dark. How much the pupil dilates in the dark. So that is very important because mostly the Lasik zone, the optic zone is 6.5 mm. So if the patient has a larger pupil size, which dilates more than 6.5, 7 or 7.5 millimeters in the dark, then you can experience more of aberration, glare. Then especially when the patient has a lot of night driving activities, and they will be experiencing lot of glare. So we have to inform the patient prior itself, like the glare and aberrations. So we should be knowing the specific pupil size and the profession of the patient before advising the patient about the things. Because after the LASIK, nothing can be done. So that is very important. Some patients will have mild aberrations, but if they have lot of activity in the night, it is very difficult. And some patients they don't have much activity, they will be having no complaints about. So it is our duty to inform everything prior to the patient to avoid such issues for the patient. And next part is the plant examination. And we have to make sure the lids are very clear. Lids are very clean without any leukomyelitis, blepharitis, which can all cause infected surgery. So starting from the lids, every part of the eye has to be examined. So we have to check for the shallow AC and the symbol. So and going to the cornea, whether any scars are there. Some people wouldn't have known that they have had contact-related infections, and they wouldn't have noticed that. Now, when we see some opacities and ask them, then only they will reveal that yes, they have some infection happened. So we have to check for the opacities, any active or any old scars that is there. Because if there is a scar, we have to wait for the scar to fade. So what we do is we send the patient for an anterior segment OCT, and we have to measure the depth of the scar. So this depth is mentioned in the file, and after 2-3 visits, we will see that the scar is faded. If it is faded, we have to get in the patient for the Then we have to check for a dryness. We have to do a Sherman test, and if the patient has any dryness in the Sherman test, we will be sent for detailed trial evaluation. And if the patient requires a treatment, we have to give the trial treatment for the patient, and then the patient will be coming back after the treatment for the therapy. And you have to make sure the conjunctiva, all parts of the eye are healthy. Now going to the retina. So now you, as optometrist, we will be starting the system examination, IOP checking, and the artimetric in the initial work. So we will be checking the thickness of the cornea. IOP also should be normal, and we will be checking the corneal thickness of the last part in the initial workup. So corneal thickness, if it is very thick cornea, we have to think about data also. We have to do a examination, and mainly in this part, we actually see the manual keratometry. Manual keratometry nowadays is not practiced in many places, but manual keratometry has its own advantage. Manual keratometry tells us about any distortions on the cornea and any doubling, early doubling in the case of keratoconus can be picked up only in manual keratometry. If you practice manual keratometry, it's a very good tool to find out any early, and also the manual retinoscopy. We would recommend the manual retinoscopy also. We can find out early symptoms. So many patients in our clinics we have found out early keratoconus just by the retinoscopy, early symptoms reflected and manual keratometry. So it's possible to do a manual keratometry, and then finally do a bathymetry, and we will be dilating the patient for the fundus examination. So if the consultant or the doctor advisor take the fundus, and if everything is normal, they will be sent back for the second part, the pre-LASIK evaluation. If they find any holes, lattice in the retina, the patient will be taken for retinal evaluation. And after 3 weeks of diagnosis, the retina is found to be stable, the patient can be taken for LASIK. So the pre-LASIK evaluation will be done at that stage. We have to repeat the refraction once more after 3 weeks of retinal array. Then go on with the pre-LASIK evaluation if everything is found to be stable. So the second part is the pre-LASIK evaluation. So which includes technically. So before the I will try to tell you that before the pre-LASIK evaluation, the patient should be advised of all the possible pros and cons of the LASIK treatment or whatever the practical doctors are. And also, if some patients are not aware that contact lenses are something is there in the practice, and the patient won't be aware. So we have to explain to them about all possible refractive corrections. Then the patient is okay. Then only to come for the pre-LASIK treatment. So mainly we do pentacam. So it's just the front cornea and back cornea we do is 5 shine plus principle. So the front previously in olden times there was only a corneal topography, which gives only the anterior corneal detail. We know that it is not enough, so we use the posterior corneal details also. So the pentacam is front cornea, back corneal details, including mainly the posterior elevation. So what this is some patients who have a very clear, very normal anterior corneal curvature, but we can see that there are posterior elevation problems in early high posterior elevation happening. So we can find out subclinical keratoconus like that in the pentacam. So without pentacam, we would have missed such a abnormality. If it was only topography, we would have easily missed out all the cases, and patient would have ended up in ectasia later, post-classic ectasia. So this procedure evaluation is very important. We have many tools in Pandakam, like CAD screening software to find out early ectasia. So the posterior vision, batch screening, everything all together, and we have so many other parameters which we see in the deviation of the net point. So many parameters with which we can find out early ectasia. If the patient has any one of these risk factors, we won't address the patient for plastic surgery. So we will be explained about all the risks, and we will not be taken for surgery. But in a new instrument called Corvus has come now, which is even more efficient to find out the early corneal ectasia. So this Corvus is an instrument which can be combined with our pentacam, which finds out the biomechanical response of the cornea. What happens is it gives air blast into the cornea. So from the response of the affirmation of the cornea, so the cornea goes back and comes front with the rest of air. So from that, the biomechanical responses is measured, and we can with the help of a few indices like TBI and CBI. For this biomechanical index and tomography biomechanical index, these two indices are an indicator of early ectasia. So the TBI and CBI values are abnormal. We should not take up the patient for surgery. That means there is a chance if the patient undergoes surgery, there is a chance that this patient can end up in ectasia at a later stage in life. So after the evaluation of this process, it's been more 3 to 3 for very early ectasia also. And next step will be a specular microscopy. Specular microscopy has to be mandatorily done for all 6 corneas to find out whether the data is there. If the data is there, we should not proceed with the order. So if we find the 6 cornea, first start with the specular microscopy. If the corneal individual help is not, don't proceed with the other evaluation. So that is the main second part. We are looking for the Lasik evaluation. And after, if the patient is not eligible for Lasik, there are other refractive surgeries also.
Ma'am, sorry to disturb. There is some external disturbances in the mic.
External disturbance.
I guess it's near the connection port or something.
Is it okay now? Still it is there?
Yeah,
Hello?
it's fine. It's better, ma'am.
Better?
Yeah, but still the kind of sounds I have been heard. Better now, ma'am.
Better now? I think I'll hold this like this. Okay. So I would just like to tell you what type of surgeries are being done for what type of errors. Okay. So femtolastic is being done. Actually, microkeratome lasik is an old-fashioned procedure. Most of the places have stopped doing microkeratome lasik nowadays. So we are using femtolasik only. So femtolasik surgery is being done up to a power of -12 diopters and a cylinder power of up to 6 diopters and hyperopia also up to 6 diopters can be corrected in femtolasik. And epilastic is where the patient has less than 6 diopter of power, then the patient can be taken up for epilastic. So epilastic can be taken in thin cornea also. 470 microns of cornea thickness or above can be taken up for epilastic. And it is a flapless procedure, so there is a chance of flap-related injuries are less for those patients who are involved in sports or are like that. If the power is low, then you can very well opt for an epilastic. Epilastic has slow healing. The epilastic, they remove the epithelium and the bandage contact lens will be placed on the cornea for 5 days. So after 5 days, the epithelium will be healed. The lens will be removed. So the visual recovery will take little longer than LASIK. In LASIK, femtoLASIK and SMILE, you can make the patient read. The refraction can be done on the very next day itself, while the epilastic takes 1 month. So we should do the refraction only after 1 month of the surgery in epilastic. And post-operative care, epilastic in epilastic SMILE and femtoLASIK, they will be giving you lubricant for 6 months. It has to be put very frequently 4 to 6 times a day, and antibiotic will be given for 1 week, and steroid has to be given in few cases, especially in epilastic for a month. The tapering dosage will be given. So the main thing which you have to remember is that in post-operative 1 month visit, the epilastic patients mostly will be using the steroid. You have to be very careful. You have to check your IOP without their IOP without fail, because there will be steroid responders who will be having a high IOP in the post-operative visit. You have to inform the doctor when I'm there, and they will be taking care of the rest of the. So post-operatively, in the day one, we will be doing refraction and topography for the LASIK and SMILE patients. Whereas in epilastic, only in 1 day, refraction and the topography or PET. And I should not forget about ICL. Many of you will be aware of ICL, this implantable polymer lens, where the LASIK is not possible in high power cases or where the cornea is thin. You can advise the patient for ICL. So your ICL can be kept in the eye for those patients, but the requisite is the AC depth, anterior chamber depth should be 3 millimeters or at least 2.9 millimeters. If it is less than that, there is a risk. So what you have to do, you have to make the patient undergo a pentecam, and those cases, the AC depth has to be checked before advising for the further tests on it. You have to make sure one thing. Nowadays, in the pentacam, you have AC depth written as external or internal. You have to make sure it is internal AC depth from the endothelium. Sometimes the patients will bring out reports from outside where you will see AC depth and you will just write down, okay, 4 mm, 3.5 mm. But you have to be clear whether it is internal or external. If it is external AC depth, it is including the corneal thickness which they have measured. So we have an IOL master, it will be from the corneal anterior surface. So we have to make sure we are seeing the internal AC depth, then only we can assess for which is more than 3. And post ICL care, we have pre-ICL is called the post ICL. Post is of the specular microscopy. How is the endothelial health of the patient? So post ICL, we have to do specular microscopy. Post ICL, we have to do the vault measurement. Every visit, we have to measure whether the ICL is facing between the ICL and the human lens. So if it see the patient is examined in approximately 3%, at least half of the corneal thickness. Like that. So when the wall is very less, what will happen? Go to the lens and get touched. That's the lens and for cataract. Closely monitor. Previously, in olden times, when ICL surgery was done, they used to do an iridotic stage.
Deepa ma'am, sorry, your voice is not audible, ma'am. You'll have to keep the mic close if possible.
Keeping it close, actually.
Yeah, now it is better,
Hello?
ma'am. Yeah, when you're asking, no, it's fine. But yeah, I think in that flow it becomes very soft.
Okay, so should I repeat anything?
No, ma'am, you can just continue from here, ma'am. Now it's much clearer.
Okay. I was telling about the vault of ICL, which you have to monitor every visit so that it should not go and the ICL should not go closer to the lens and touch the lens, causing cataracts in future. So that is a very important measurements. In every visit, you have to see the vault of the ICL, and the specular microscopy has to be done. Okay, and what else I have to and smile surgery is the new method where there is a no flap. There will be a lenticule which is removed according to the power of the patient. The lenticule is removed and it gives a faster healing. So but the disadvantages only two diopter up to 2 diopter of astigmatism only can be corrected, and hyperopia cannot be corrected. Otherwise, smile is also a good option for the patient. So the main part of the Lasik workup we have covered now. I think if anything missed, you can ask. As optometrist, our role in Lasik selection of patients is very big because it is a life-changing procedure for the patient, and it is an irreversible one. So once again, I am reinforcing the importance of the pre-Lasik evaluation. Sometimes the pentacam might show variable readings due to some abnormalities, any test done, applanation tonometry done, or anything. We can always ask the patient to come on another day, do a fresh test without doing any other test on the cornea, directly do a pentacam, so that we can make sure, double check and make sure it is normal or abnormal. One more thing I want to insist is we have to do it in an undilated state. We would suggest you do the pentacam without applying fluorescein or without dilating the eyes, because we have done a study and found that there are cases where there is a lot of difference in the readings with the fluorescein and the dilated state. So maximum possible you do the test in an undilated state. So while during the initial workup itself, you found that the patient has a very normal retina in his old reports, and you have all reading stable, keratometry, everything is good. Then if the patient is willing and your consultant is willing, you can always go ahead with a pre-LASIK evaluation along with the initial checkup and finish off the test in a single day, and the patient can be dilated after the examination. If it is possible, that is the best way. Or the patient can come on another day fresh, then undergo the test. And I think I have covered most of the points.
Thank you so much, ma'am. It was a very, very elaborative session. We understood how you narrated how to pick up a patient for LASIK till what technique can be used for different patients. So the entire flow of the LASIK workup along with the techniques to be used was detailedly covered. And I have few questions for you, ma'am, from the student's perspective. To summarize or to know it in a very crisp and short manner, who are contraindicated for LASIK?
Contraindications are who are less than 18 years of age, who are not stable in their power, and the patients who have high unrealistic expectations, they are not to be taken for LASIK, because we have anyway, we have to tell the patient like we are expecting a good result, but still there are chances that 90 to 95% of correction may happen. There are chances that 5% can be 0.5 or 0.5 power can come this side or that side. The patient is very well accepted patient who has who understands the risks and everything. That patient only has to be taken up for LASIK, because it is making your cornea thinner and flatter, so it's no longer a virgin eye. So you have to be sure that the patient is informed of all the risks involved, and they are okay for the surgery. Then nobody should be compelled for LASIK surgery. If the patient is coming on their own and asking for the procedure, then only you have to take up, and also you have to inform them about all possible options. And the next contraindications are what I told. The systemic contraindications I already informed. So all those patients are only contraindicated.
Thank you so much, ma'am. The next question will be cylinder patients, the astigmatic patients, can they come for LASIK? If
Yes,
so,
yes.
what diopters can be corrected?
Up to 6 diopters astigmatism can be corrected, provided the patient has good corneal thickness, and also all the parameters in the pentacam is very normal without any early signs of ectasia.
So, ma'am, the next question will be what measurement errors can affect the LASIK predictive values?
LASIK errors. We are not supposed to make any error for any LASIK patients, and no error is permissible. So everything can affect. The K reading can affect. The power refraction can affect. Overcorrection, undercorrection can affect. Thickness values can affect. Pentacam, if you miss out to find out some early ectasia, can give a disaster to the patient. Pentacam and Carvey. So whatever test you are doing, do it in, with 100% perfection and dedication.
Thank you so much, ma'am. The last question will be what is the minimum corneal thickness that we can proceed with the LASIK?
Yes, I told you already, femto-LASIK can be done only if you have 500 microns of thickness. That can be done. But if full correction is possible or not depends on how much power you have. So there is a formula, there is a nomogram software in which we will feed the scotopic pupil size and thickness of the patient and the power. So you can approximately, you can calculate like this. If the patient has 5 diopter of power, the 1 diopter of power removes 10 to 12 microns from the cornea. So the 100 microns is for the flap, that has to be untouched. 100 microns of cornea is for the flap, and 250 microns of residual bed, stromal bed, has to be kept risk free. So after removing this, after keeping this much in margin, then how much power can be corrected, so that we can calculate. So that is the calculation which gives whether you can fully correct or correct. So 12 to 13 microns for 1 diopter of power. So like that is the calculation of nomogram. So then we can find out whether it can be fully corrected or under corrected. So if the patient has very less power and 470 patient has no 500 microns is not there, he cannot undergo femto-LASIK, but he has an option of epi-LASIK if he has 470 microns or higher thickness, and if he has less than -6 power. If the patient has -8 power, 10 power, and still he has 470 only thickness, so he has no option of LASIK, no option of LASIK also. He has the option of ICL. Even if the patient has a keratoconus also, you can undergo an ICL. We have some patients who had a very stable keratoconus over many years. They have undergone ICL and got a very good result.
Thank you so much, ma'am. It was a very detailed and elaborative explanation of whatever your input was, and your answers to Q&A was very useful, ma'am.
Thank you.
Anshi, ma'am, do you have any questions for our moderator today?
Hi, ma'am. No questions as such, but I was very happy that ma'am was able to give such an elaborate explanation to us. So thank you, Smruthi, for such a wonderful presentation, and thank you, Deepa ma'am, for adding on the value of that very important sentence of that Lasik. Once done, it is irreversible. So we have to be very careful about all the procedures that we do, whether it is pre-Lasik or post-Lasik. So optometrists play a major role. So thank you, Deepa ma'am, for bringing it out completely. Thank you so
Thank you,
much.
Anshika. Thank you all for the opportunity. Thank you.
Over to you, Gomati.
Thank you so much, Deepa ma'am. That was a wonderful explanation, ma'am. Thank you so much for joining with us today. And thank you, Meenakshi, for conducting the Q&A session as well. And Anshi ma'am, we have a very exciting workshop happening this weekend. So we'd like to hear from you more about that, ma'am.
Yes, Gomati. So at Dr. Agarwal's Institute of Optometry, we are organizing a reports interpretation workshop. It is going to be held on 27 July from 9 a.m. to 1 p.m. And we are going to have 3 eminent speakers who are going to explain and teach us how to read an OCT report, a fundus image, as well as a visual field report. So we still have the registrations open due to the high demand. So there is already, we have the link shared in our Insta page as well as in all the links which are there of the college. So if any of the students who are viewing this are interested, please do join in. It'll be a great learning.
Thank you so much for that information, Anshi ma'am. Dear audiences, thank you so much for your continuous support towards Optometry series. We'll meet you in the very next episode. Thank you all. Thank you, ma'am.